Mitch, can anyone be a flame operator? I mean, what's it take? I mean, how did you get started? And, is this scalable?
Mike, I think it is, and I think Dr. Jaber touched on this. I don't want to minimize the complexity of PE intervention, but it's technically not that challenging of a procedure. And once you get about 10 under your belt, you probably can take on the massive patient that's unstable. This notion that large bore thrombectomy stuffs the clot and does all these things, and there's interactions with the tricuspid valve, we just don't see it. I can say with a high level of confidence, it's a safe procedure. It really is. And I think Flame, for what Dr. Geary said, I agree, does show in the perfect storm that it treats patients with high risk PE. And Dr. Jaber's example of his ER doctor saying, well, maybe we should lyse the patient. That's what's in the front of most ER doctors' minds. And as Dr. Geary said, we got to get away from that. If Dr. Jaber's there, like he was in the case he showed, and comes to the ER, promptly sees the patient, gets him up to the cath lab, has the experience, it works very well. It's a very safe and efficacious procedure in these high risk patients. Now, quickly, I'm a firm believer in intelligent care pathways, and I think that's where the field has to go. Venous in general is an orphan. None of us learned a lot about it in medical school. So the approach, DVT and PE, is very fragmented. It's very chaotic. It's very inconsistent depending which ER doctor is there that sees the patient with a swollen leg or a PE. We now have the ability with intelligent care pathways and mobile apps to have care pathways that are evidence-based, that risk stratify patients and tell doctors this patient should have a PE intervention. Is it a lytic? Is it a thrombectomy? They need something done versus medical therapy. I think we can get there with artificial intelligence and that. That's really where the field is going to go, is intelligent care pathways.
Yeah,
Mitch,
you're aspirating out.
if you don't mind me adding on there, one other thing that I think we have to really think about in terms of increasing capacity to treat these complex patients, it's not just having the doctors, right? There are highly trained staff. There are folks who are intimately familiar with the physiology, appropriate considerations regarding sedation and anesthesia, uh, in certain circumstances, consideration for mechanical circulatory support. It takes a whole village here of people. It starts with the interventionalists, I think, but also must include cath lab nurses, cath lab staff, sometimes surgical staff. And everything that I'm seeing across the country is that the system is being taxed, to the limit with staffing shortages. And frankly, I think BTE and pulmonary embolism gets short shrift. I'm traveling today. I was with a hospital today that they said, yeah, every time we do a PE case, it gets added on at the end of the day after the patient's been, languishing for 24 hours. Nobody wants to do it because it's not part of the routine and they're not comfortable. And then there's, no surprise why the patient has a complex procedure or is challenging. And I think we need to prioritize this disease state. If you look at the mortality of this disease state compared to where we are with heart attack and stroke now, I dare say this should be square in the sights of folks who want to reduce cardiovascular mortality.
I agree. As someone whose both parents had PEs, we really got to move this up the ladder in terms of our paradigms of treatment.